Cortical vision impairment. Okay, so welcome to the session on cortical vision impairment. Today we will discuss all the characteristics of cortical vision impairment. We are fortunate to have Christopher Russell, MSED, who is project coordinator at the New York Deafblind Collaborative. He has kindly brought a number of different programs for CVI, and will also describe characteristics and how CVI works with our children. So Chris, thank you.
Okay, thank you so much. Can everybody hear me okay? I can hear myself very well. All right. So good morning. It's so nice to be here with you all. I'm going to try to condense into an hour what I could easily spend a day talking about, or even a couple of days. So I've managed to do it before, but if I go off on a tangent, then I might be playing catch up. So feel free to interrupt with questions. I like to make these kinds of things as interactive as possible, but there is a ton to get through, and my hope today is really to provide sort of a comprehensive overview, so a very functional definition and functional understanding of what you can look for in your own child, or if you're a professional, in the children that you work with. With an actual intention to make an impact on your own approaches and strategies towards working with your child. So all of the information that I'm speaking about today really comes centrally from the work of Dr. Christine Roman Latency, and it's the specific approach to understanding cortical visual impairment that she's developed over the last 15 years or so. This is a relatively new field, and it's a field that is emerging constantly. There's new information and new approaches emerging, and new research as well. So it still very much is a work in progress. Dr. Roman herself would say that there really is nobody who is completely an expert in this. We're all learning about it together. So credit where credit's due. This kind of results from a long collaboration that I've been doing with several different professionals across the country in terms of creating content that's really geared towards families and professionals equally. And just to give you a little bit of background and context, I am currently the project coordinator of the New York State Deafblind Collaborative. Basically, every state has a grant program that's funded by the U.S. Department of Ed, the Office of Special Education Programs, that provides free training, consultation, and then more kind of intensive, individualized support to families and to professionals who are working with or have kids that have both vision and hearing loss. So 5-year grant cycle through the U.S. Department of Ed. So most of what I do is really coaching and training for professionals, because my background is as a teacher of the blind and visually impaired and a classroom teacher working with kids with multiple disabilities. And I have in the past, in about 7 years of teaching or so before I got into this position, worked with 2 kids who had CDKL5 disorders. So it's a really dear population to me, and I'm honored to be here with you guys. So to give you a sort of a nice compact definition of what is cortical visual impairment, or CVI, it is essentially vision loss that is due to some level of damage or impact to the brain. Most typically in kids with CVI, there's nothing really wrong with the eyes. The eyes are functioning fine. Or if anything, there's maybe a mild ocular motor disorder, which we'll speak about briefly. But it's really the brain and the impact of visual processing in the brain itself. So visual information is coming in through the eyes just fine. Something is happening in terms of the processing deeper in the structures of the brain. We'll really get to the core of that. CVI is really now thought to be the leading cause of visual impairment in young children in developed countries. And sort of talk about the developed countries aspect of it, it's really because of advances in medical technology in developed countries. So causes of visual impairment that used to be more prevalent in countries that had strong medical care, especially for neonatal intensive care units and perinatally. A lot of those causes, like retinopathy of prematurity and some of the ocular stuff that was more prevalent in the past, is now more easy to prevent or treat. But at the exact same time, we're seeing an increase of children, especially with major birth complications, with strokes or seizures around birth, and also just very premature infants who are surviving at a much higher rate than they would have 20 or so years ago, but with a much higher risk for neurological impact. So that's why CVI is really getting a lot more attention than it did in the past, and it really is an increasing population with an increasing field of research, fortunately as well. Just to clarify, you may have heard the term cerebral visual impairment. You may have heard cortical blindness too, but the confusing one is cerebral visual impairment. It's really not the same thing, and there's a great and very appropriately named article by Dr. Jan. You can Google, called Cerebral Visual Impairment and Cortical Visual Impairment are not the same thing. So that kind of tells it very, very aptly. But it's really, cerebral visual impairment is a broader term. Cerebral visual impairment describes a whole category of neurological visual processing disorders that even include things like dyslexia. So when you hear that term cerebral visual impairment, be cautious of accepting strategies and approaches that are specifically targeting that term. It's a big controversy, and it's a hot topic in the field of blindness and visual impairment, and it also is sort of a trend that cerebral visual impairment is being used more commonly in Europe, whereas cortical visual impairment is being used more commonly in the US, but they're really not the same thing. Cortical visual impairment is much more specific and speaks about a very specific category of neurological impact on vision. Okay, so CVI is different, very different from other non-brain related visual impairments. Over here on the top left, we have sort of a basic structure of the internal workings of the eye. And if an individual has an ocular visual impairment, you really need to know exactly where that impact is. So if it's in the lens, then it might be a cataract. If it's in the sort of the aqueous parts of the eye, the middle section of the eye, the vitreous humor, or in the sort of front of the eye, it could be glaucoma if there's extra pressure. If it's in the back of the eye and the retina, it could be a retinal issue that relates to field deficits or spots in vision, or even like macular degeneration would be right at the back of the eye. So with ocular visual impairments, we can tell a great deal about what the individual is seeing if we just know where to pinpoint the damage. Where is the damage happening? We can expect, cataracts look very, very different from glaucoma and have a totally different impact. With cortical visual impairment, it's not really that easy because we can't see what's going on. We can't pinpoint exactly where the damage is. There's a lot of emerging research in neuroscience that looks at sort of what do MRIs tell us about cortical visual impairment, about where the damage is, how severe the damage is, what do we expect the implications of that might be. And anytime that I've heard from these brilliant neurologists who are at the sort of cutting edge of this field of research, and I've asked them, what do we really know about this? And they say, basically nothing. So it's still really an emerging area in terms of understanding what's neurologically happening. It's largely based on theory at this point. So, however, children with CVI can have ocular visual impairments in addition to the neurological damage that's happened. The most common one that I've seen is strabismus or amblyopia. It's an ocular motor issue where the eye is either sort of turned out or is drifting out, right? That is a very common thing that I'm seeing in kids with CVI. The reason for that is that there's all kinds of different other neurological things that can cause that damage. So if your child or if somebody who you're working with has a visible amblyopia or strabismus, a visible ocular motor issue, you definitely need to see an ophthalmologist for that, and specifically an ophthalmologist who has that background. And the biggest thing to think about, if that's the case, is could this child benefit from some level of treatment, including patching? So if it is an amblyopia where the eye drifts out, and basically one eye starts to get used more than the other. So the eye that's focusing, that's not drifting, becomes stronger. The eye that's drifting stops being used, and vision can actually deteriorate. So what they do is they'll recommend patching the good eye so that the eye that's having more trouble will have to be used more, it gets stronger. That's really only recommended, it's really only possible to treat that up to around age 8. So if you have a young child who you're observing those behaviors in, or you can sort of visually observe it, it's really important to get that checked out and ask, could my child benefit from some level of treatment and patching? Okay, so CVI is suspected. In order to suspect CVI, you need to have 3 central criteria. There's 3 main diagnostic criteria. So there has to be some history of what we'll call neurological event. So this can be a wide range of different things. Obviously, for kids with CDKL5 deficiencies and disorders, it's really about the impact of seizures. Okay, unless there's been some other neurological event. The most typical neurological event causing CVI is perinatal hypoxia. So lack of oxygen to the brain at birth or an interruption of oxygen flow to the brain at birth, which causes deterioration of the white matter of the brain very early on. For kids with CDKL5, it's most likely the impact of specific locations of seizures in specific areas that cause CVI. Now, what's really important is that whatever you're observing that's abnormal in visual behaviors in the child, you should get it checked out by an ophthalmologist. So the second criteria is really that the medical or the clinical eye exam cannot explain what you're observing. It's important to rule that out because if there's something else going on, it requires a whole different response and treatment. And then finally, what we're really going to spend pretty much the entire rest of the time talking about today is the presence of unique visual characteristics that are very specific to CVI and that really couldn't be explained by pretty much anything else. So population statistics, this is taken from the CDKL5 disorder output database, and it shows sort of roughly, I don't know, what's that around, maybe 1/5 of kids with CDKL5 disorders have reported cortical visual impairment. Okay? And it's key to say reported because it's my suspicion that the number is probably much higher. And that's what I've heard from pretty much everyone that I've talked to who has a child or works with kids with CDKL5 disorders, is that there's probably a large number of unreported cases or maybe just undiagnosed cases. And we'll talk about that a little bit too. So some sort of FAQs here, some frequently made statements even. The clinical eye reports were normal, or my favorite one is the wide range of acronyms that you'll get from an ophthalmologist. UTT, unable to test. That basically just means I don't know what I'm doing. Right? Because there's no such thing as unable to test, especially when it comes to functional vision assessment. So the clinical eye reports come out normal or unable to test, but I know that my child's vision is not typical. So does the clinical vision specialist, whether it's an ophthalmologist or an optometrist, do they recognize or diagnose CVI? The best thing you can do when making an appointment with an ophthalmologist, if you suspect or know that your child has CVI, is to ask before you even get to that appointment, does this clinical specialist recognize or diagnose CVI? If they don't, go to someone else. Because for a lot of ophthalmologists and optometrists, their whole background and focus is on ocular visual impairments. So they really don't necessarily have the background and expertise, and they may not even buy into the idea that this is a real thing. I've actually heard that before. So I would suggest trying to go to a neuro-ophthalmologist if that's possible. In New York State, we started to come up with a list of basically all of the clinical vision specialists who we know to diagnose CVI or recognize it, and then all the ones that don't. So it's sort of a secret document, but anytime someone reaches out to me, I can tell them, go to this person or don't go to this person. I'd love to see that nationally or even internationally. Follow-up clinical assessment with a functional vision assessment. Okay? And the functional vision assessment for CVI is the CVI range. There really isn't another functional vision assessment for CVI. We'll talk about that a bit too. So can CVI be diagnosed clinically, and is it important to have a diagnosis? Yes and yes. Diagnosis is important to qualify for specific services. I know we have an international crowd here, and so The criteria for eligibility for services or how you go about getting services is obviously going to be unique to where you are. But diagnosis is pretty much always important for that. And then most importantly, to make a plan for functional progress. Okay, that's what this is really all about. The other one that I get is that the functional vision assessment itself does not address CVI. Okay, so somebody, a teacher of the blind or visually impaired especially, has gone into your school or worked with your child and done a functional vision assessment to make recommendations for what the child needs at school or at home, and it really doesn't have anything to do with CVI. It's about visual tracking skills and scanning and shifting gaze and all of these sort of visual skills that are much more specific to ocular visual impairments. Same thing as with the ophthalmologist. Does the TVI or low vision specialist have training in CVI and in CVI assessment? This is a really hot topic in the field of visual impairment that kind of have to be careful what you say in the wrong audience. You can ask for the CVI range as an appropriate assessment of your child's functional vision. That's the biggest thing I would say to parents. And I highlight that word appropriate for you folks who are US based, because that is your legal right in IDEA, right? In the federal law, your child has the right to a free and appropriate public education in the least restrictive environment possible. The only thing appropriate for CVI assessment is the CVI range. If somebody would offer a different tool that was maybe appropriate, then we could talk about it, but at this point, it's really the only appropriate tool. Okay, anyone with training can administer this functional vision assessment, the CVI range. It does not have to be a TVI. However, only a TVI or a low vision specialist can do a functional vision assessment for legal mandates, to make legal recommendations for services. So if you're just talking about getting great information, I know speech pathologists who are better than most TVIs in administering this kind of assessment. I know OTs who are better at it. I know parents who are better at it. But in order to actually make those mandated service recommendations, it has to be a TVI. Okay, so now to the real important stuff. Why is it important to identify and assess CVI? This is what's really unique and actually really exciting about CVI, and this is where I like to tell people this is a good thing that we know that this child has CVI, because with CVI we can actually expect an improvement in visual functioning with the right intervention. We should actually expect improvement, not just in the efficiency of your child's use of vision, but in the actual visual processing. So with intervention with CVI, we're actually making improvements in the connections of the brain. But it does have to be based on assessment, and the reason for that is that there's very different approaches to intervention based on where your child falls on what's called the range of visual functioning. It's almost like a wide spectrum of visual functioning. Very, very different from one end of the range, most severe, to another end of the range, least severe or most kind of typical use of vision. Intervention has to be a team effort. It can't just be the TVI, the teacher of the blind visually impaired. It can't just be happening in the classroom. It can't just be happening in the family. I think this is probably kind of preaching to the choir, but if you have TVI services, you have vision services or speech services or OT maybe 3 times a week for 30 minutes, that's really not enough to make a change in the brain. There has to be a shared practice for everyone. Okay, so I am not a neurologist, so I'm going to give you the very, very basic version of what's happening in the brain. Basically, this is what's happening in the brain with CVI. We have 2 main streams, almost like highways of visual processing in the brain. There's the dorsal stream and the ventral stream. The dorsal stream gives you information about kind of where things are, information about movement and form or shape, information about lighting, and information about sort of the general details of things. Nothing sharp, nothing acute. The ventral stream gives you information about detail, about what it is that you're looking at. So when you're using your central vision, when you're looking directly at something, making what's called eye-to-object contact, looking straight at something, you're discerning what is it that I'm looking at, and you're getting lots of detailed information about it. The dorsal stream develops first, and then the ventral stream kind of develops secondary, and the two come together And in typical visual processing, we're using both of those streams all the time. So basically, progress in visual functioning for kids with CVI is about integrating the dorsal and ventral streams. On the lower side of visual functioning for kids with CVI, on the lower side of the range, they're using their dorsal stream much, much, much more and more effectively. And it's not till a little further on in development that kids with CVI start to use their ventral stream. So, with ocular visual impairments, you can put on some goggles and do a simulation of what does this visual impairment look like. For CVI, we can't really do that. But the best sort of mock simulation I could give you is if you just look directly in front of you, look straight ahead, don't move your eyes, and don't move your head, and tell me how much can you tell about the person sitting next to you on the right or left? Can you tell that there's someone there? Yeah. If you didn't know who it was, could you tell enough about them to figure out who they are? Can you see the detail on their face? Is anyone sitting next to someone who has a really bright shirt on? Brightly colored shirt. Yeah, you can see the really brightly colored shirt. Is anyone sitting next to someone who has a detailed pattern on their shirt? Stripes or... Yeah? Can you tell if it's right next to you on the right or left side, not in front of you? If you're sitting next to somebody who has a detailed pattern on your shirt, can you make out what that pattern is? Or does it kind of blur? Right? You can tell that it's there, but it kind of blurs. Now imagine if somebody held a paper with writing on it up to your peripheral side when you're looking straight ahead. Could you read it? No. You couldn't get the detail from it, right? Could you tell that there was something there? Yeah. Okay. So that's because in that simulation, your peripheral vision, you're using your dorsal streams. You're getting a lot of information about form and shape. You can tell lighting. You can definitely tell bright colors. You have a lot more difficulty with detailed patterns, with text, with anything that requires sharp visual acuity. It's been described as like looking through a kaleidoscope. So this was actually a description made by a young woman who has CVI, who was able to articulate this, and she basically said that going through the world was like looking through a kaleidoscope, and that things that were very, very busy became impossible to figure out. So if you imagine looking through a kaleidoscope at a complicated picture with lots of detail and lots of different characters on it, imagine looking at a picture book through a kaleidoscope. It would all kind of blend together and be hard to figure out what was what. Whereas if you look through a kaleidoscope at a bright red ball against a dark black background, you could probably tell what it was. Right? So we'll come back to that when we talk about characteristics. Oh yeah, okay. So there's 10 characteristics of CVI. We're really going to spend the rest of the time trying to kind of shuttle through this, and we'll get through as much as I can. But we're going to go through each of these one at a time. And as we go through these 10 characteristics of CVI, we'll talk about how does each characteristic impact the child's visual functioning. That's what you're thinking about. So when you think about this characteristic as it applies to your child, how does it impact your child's ability to use his or her vision throughout the day to access information? And characteristics affect children differently as their visual functioning improves along this range of visual functioning. So the range is basically 0 to 10. There's 3 phases of CVI. The most severe, or phase 1, is basically 0 to 3. And then phase 2 is sort of moderate, that's 3 to 7. And then phase 3, which is the least severe, or the most typical visual functioning of CVI, is 7 to 10. These characteristics look very different as they go through the range. And if the characteristic has no impact on your child anymore, then we can think of it as resolved. That characteristic's resolved, they've moved past it. Okay, so color preference is the first one. For kids with CVI, they typically have preserved color vision. They have a much easier time seeing bright colors, just like in your simulation. If you were sitting next to someone that had a really bright item of clothing on, it tended to kind of pop out. And that's because use of dorsal stream is much stronger. Kids with CVI often will only look at certain colors, red or yellow, or really any bright, saturated colors. In general, even further along the range, kids with CVI have trouble looking at pastels. right? Pastels are going to be difficult. They're not highly saturated, they're kind of dull, and so they don't pop out, they might blend into the background. So further along the range, if the child is now able to look at many different colors, not just red and yellow, they may still benefit from color to highlight important information, or sort of to provide an anchor, bless you, to provide an anchor for what it is that you're trying to get them to look at. So because I came from New York, I didn't bring my whole kit of materials, but usually I'll usually bring like some red tape and wrap it around the microphone. And it really focuses. You can tell how much it focuses your attention. So something really interesting, using the dorsal stream alone, you can get information on color. And something fascinating, you don't actually even need to have a connection between your eyes and your brain to perceive red. Red you can perceive with your eyes alone without the information even going into your brain. So that's actually an evolutional trait that's based on things in nature that are red being stay away from, right? So some examples, kids with CVI looking at bright saturated colors. We'll see how this sort of pom-pom example, it also combines with another characteristic, which is movement and light, the sort of reflective quality. Really, kids with CVI having an easier time being able to look at items that are one solid bright color, especially if it's against a background that isn't as complex or as cluttered. Elmo is terrifying, but highly enjoyed by kids with CVI quite often, right? Because it's a bright red color, not a lot else going on there. You can imagine that in that simulation, you'd have a pretty easy time perceiving Elmo to your side. You might even be able to identify what Elmo was or who he was, even without looking directly at him. Right? Slinky is also our best friend of kids with CVI quite often. Bright primary colors, very easy to see, they contain a lot of movement, right? So further down the line, this is where we might see color as a point of intervention. And this is what's really exciting, is thinking sort of innovatively about if color has a big impact on your child, what can you do to use color to support the child's visual attending, the child's visual functioning. So this is a little one who was having trouble using her vision at all during eating, because eating's a really complex activity. There's so much going on. And so kids with CVI in these types of complex activities may tend to look up at bright lights or just kind of stare off into the distance or look away. If you can give them a visual anchor to focus their attention, it really highlights and it really pulls the visual attention to something functional. This was an interesting one that I saw a classroom teacher make. She was trying to show the student where the light switch was in the classroom, so just kind of took red tape and wrapped it around the light switch a little bit. Could do the same thing on a locker. Actually, that's what's right here. On a student's cubby, right? Yellow tape on the cubby. Could do it on a chair, on the classroom door. Anything that you want to use to anchor visual attention, you could use color in this kind of a way. Now, even a little further down the line, this was a really cool classroom adaptation where in a morning circle activity, they were doing a head, shoulders, knees, and toes song. So they had just used a little bit of red puffy paint to highlight the head, the shoulders, the knees, and the toes, and point it out as they went through the song. And it really allowed the child to focus rather than looking at this sort of busy, complex thing that really didn't have anything to focus her attention. For communication, and this afternoon we'll talk really specifically about this, for communication, using red as a highlight around a communication system, around the symbols of a communication system, to really separate them and show these are two separate symbols so that they don't blend together in that sort of kaleidoscope way. Okay, look at my fancy animation. So the second characteristic is movement. Kids with CVI often need movement to attract their visual attention or to sustain their visual attention. So meaning that I'm not seeing something, and here's my favorite tool, right? Bright red light, highly interesting to kids with CVI. It could be that the child with CVI is not seeing this because it's stationary. As soon as it starts moving, you'll see the visual attention shift. Or if it stops, then it's not there anymore. It's almost as if it wasn't there. And you can observe that because the child's really not even orienting toward it. For kids with CVI who are a little lower on the visual functioning side, if they're not up into higher in phase 2 or phase 3, it won't necessarily be a direct eye-to-object look. It'll probably just be like a shift and an orientation. But you can tell that your child is looking. They're not looking directly at it yet. Okay. Children with CVI may only look at something that moves or has a movement quality, like a shiny pom-pom or a bright light. This often helps kids with CVI with mobility, and this is where very often you have to correct professionals when they say, oh no, your child is doing fine, they use their vision really well. Look, they're walking around, they're shuffling around the school, they're avoiding obstacles. That's because they're moving. Right? The other really interesting thing, and I just went to this really wonderful talk I know a lot of you were at on movement disorders and CDKL5 deficiency, and I would sort of be interested in thinking about this other characteristic that I observe really commonly in kids with CVI, which is shaking their head back and forth or moving their head back and forth, or even using some of the sort of stereotypic hand movements that are sort of typical and of course are involuntary for kids with CDKL5, but if they're doing it in front of their face or if they're moving their head back and forth, it may be a visual stimulation. So a lot of times we see kids with CVI moving their heads back and forth, and people say, no, it's just a sensory stim. Well, it could be that the world is really boring because I can't see anything when I'm not moving, but as soon as I start moving my head, the world is moving and suddenly I can see. So the way to test that, if you see that happening, is try moving something in front of the child. And if they stop moving their head when something else is moving, then that's what they're doing. Okay, so further along the range, kids with CVI may be able to see things that are not moving, that are stationary, but movement will help at a distance, at a further distance. Or movement will help for unfamiliar or complex materials, or even just to redirect attention. So movement in kids with CVI, sort of straightforward there. The next characteristic is visual latency. Kids with CVI tend to have a visual processing delay that can be pretty wide range. It's different from motor latency and from cognitive latency. Okay? It's the time between when something is presented visually and when the child orients toward it or notices that it's there. I've seen latency as much as a minute and a half, something moving back and forth in front of a child, not seeing it, and everyone said to me, this child doesn't see anything and is totally blind. And after a minute and a half, sure enough, there was a nice shift, and it was very clear and consistent. Further along the range, latency decreases with warm-up time, or you'll only see latency when the child is stressed, overwhelmed, or overstimulated, or in really unfamiliar or really complex, busy environments. Right, so this is a good example of sort of what that non-direct look can look like. It's not an eye-to-object shift. It's sort of an orienting towards something. But it's very clear. You just may need to wait. Really, the only intervention for motor or for visual latency is to wait. Next one here is visual field preferences. Children with CVI often have field losses or very specific field preferences. The typical progression that we see is one strong at the sort of lower side of the visual range, one strong peripheral field, either right or left, right? So only seeing something in the right side or only seeing something in the left side. And then as their vision improves, both peripheral fields, right and left, and then upper, and then central. And then for some reason, it's almost always the case that kids with CVI have difficulty with their lower visual field. Okay? It's usually the very last to resolve, if it ever resolves. So that obviously has a pretty direct functional impact on education, right? On school. Because at school, the majority of information is presented on the table in your lower visual field. So a very go-to recommendation or adaptation for kids with CVI at school is a slant board. Just lift it up. Or get a little sort of stand to lift materials up. Or if your child is using any kind of communication device, it needs to be lifted up on a sort of, bendy arm, or on a slant board. Right? That obviously, that comes into the biggest challenge area in terms of mealtime stuff, when mealtime is presented on a tabletop. You can get innovative. Okay, so peripheral field, really, really typical, something presented in a peripheral field and a shift toward it. This was a really interesting adaptation that I saw for a little guy in Brooklyn, where he had really strongly developed peripheral fields and was starting to have emerging use of his central visual field, but he was so distracted by the peripheral information, so especially in a very busy classroom. And so the teacher put one of those trifold boards that we usually use to present information in front of a kid, put them behind him with the arms on either peripheral side, and it actually prevented him from being distracted by information on the right and left, and enabled him to use his central visual field and make that stronger. Okay, this is sort of the really big one. So everybody remember Where's Waldo? Got the right generations in here? Okay, so this is another analogy that's sort of commonly made. In addition to the kaleidoscope, it's that for kids with CVI, the whole world kind of looks like Where's Waldo? It's very complex, there's so much going on, and it's really hard to tell where is that thing that I'm trying to look for. How do I find that thing that you're telling me is here? How much easier would Where's Waldo be if you highlighted Waldo, right, using color? So color might be the tool for one student, for one child, if color is especially interesting or important to your kid. For another child, it might just be all the extra complexity that's too much, so actually blocking it off, right? Making a window, just a piece of cardboard. If you're introducing a picture book to a child, make a little cardboard window, get a piece of black construction paper and cut a hole out so you can block off all the background information, show the child this is where Waldo is, and then take it away. Now can you find it? So there's 4 different types of complexity, and I think this is really the most important thing about CVI is understanding these 4 types of complexity, because this is what really has the biggest impact on kids with CVI. So the first one is complexity of the array. If you think about the array of materials, the array of visual objects or items or targets that are in front of you, think about looking at this, this basket of stuffed animals through a kaleidoscope. They all blend together. It's very hard to pick out that one that you're looking for. But if you just pull that one that you're looking for out of that complex array and put it against a more simple background, it's very easy to see. And even through a kaleidoscope, it's easy to see what we're looking at. So it's really about the background information. This is sort of one of the tests that I use for visual assessment for kids with CVI in terms of complex array. So can you find this little goldfish, right? Can you find this little plastic goldfish? Bright, saturated color, can you find it against a totally non-complex background with nothing else around it? Now, can you find it against a black background but with some other things around it? Notice that they're not touching the other things, because if they were, they might blend together. So can you find it here? If you can find it here, can you find it against an increasingly complex background, a pattern background? And now, can you find it against a really complex pattern background where it actually blends in or is camouflaged against the colors that it's on? And I've seen kids with CVI on various points on the CVI range who can get to any one of these stages or who drop off at any one of these stages. So you're trying to figure out sort of what's the threshold for complexity. How much complexity of array can your child deal with and still find what they're looking for? You don't want to over-adapt, and you definitely don't want to under-adapt. So this was a really interesting one, a really nice example of a CVI adaptation, just separating out the complex array by putting the item that the child was looking for in a really bright, sharply contrasting bin. Because now it's contained in the bin. It's not against the background array of the floor and your feet and all the things that are kind of possibly blending in together. These are the CVI complexity sequence cards. So for kids for whom these are accessible and we're really trying to figure out like the fine details of it, this is more kids in phase 3 of CVI at the most typical, closest to typical visual functioning. We're trying to figure out how much can we deal with. So this is, I have an example of them. So first you're looking at basically a sequence of things getting more complex. You have this bright yellow flower, and then you have the bright yellow flower but a little smaller, and then you have the bright yellow flower against a sort of complex background, but there isn't so much going on. This one would be the one of the dog, maybe 10 steps along the way. So when things get really complex and the flower is still there, but it's raining and there's other flowers around and there's a fence and there's a rabbit. So how much complexity can your child really deal with processing at one time? And again, is it easier if you block off the rest of the background to provide at least a preview of what the child's supposed to be looking at? Okay, so the next kind of complexity after array is complexity of the target itself. So which of these things would you say is the least complex, the most simple? Right, the duck. Right? It's a bright, saturated color. There's a little bit of detail in the face, but you imagine looking at that through a kaleidoscope, it's going to be pretty easy to identify. And then after that, what would be the next? Probably the ball, right? So it's a couple different colors, but it's not too complex still. And after that, probably the stacking rings. They're bright, saturated colors. There's some complexity there. The colors could definitely blend in together. And then finally, this little toy where the colors are kind of all over on top of each other. That's pretty complex. So you can sort of think about target in the same way as you thought about array. At what point does your child sort of drop off being able to visually handle or process the complexity of information on this particular thing? This one's fun for everyone. The next kind of complexity is complexity of faces. So very typically in kids with CVI, you see difficulty looking at faces, difficulty making eye contact, and then as the child progresses in their visual functioning, you'll see that they can regard, sort of look towards, and then even make eye contact at familiar faces, but they'll still have difficulty looking at or regarding unfamiliar faces. And then finally, as that gets resolved, a child can look at and make eye contact with familiar and unfamiliar faces. So this is important for anyone at school or in a therapeutic setting that's working with your child. If they say, I'm not seeing what you're seeing at home, that's because at home it's totally different. Your child is much more likely to have higher level of visual processing, much higher level of visual skills in a familiar setting with familiar people, because CVI is all about experience. It's all about how much experience have I had looking at things. So you can kind of tell who these people are. All right, everybody kind of figure out most of them. They're blurry, but you can definitely pick them apart. The reason that you're able to identify characters here is because they're familiar to you, right? They're faces that you've seen often, and so it's not as difficult to pick apart even blurred facial features. So that's what kids with CVI are dealing with. It's newer faces or faces that they haven't had as much experience with are much more difficult to process. And that's because complexity overlaps with familiarity, with novelty, which is another characteristic. This is one that I think is particularly important to kids with CDKL5 and other conditions in which there's just a lot of different kind of stuff going on that we're focusing on. We're focusing on movement issues, we're focusing on availability for learning in terms of seizure activity, we're focusing on communication, and it's complexity of the actual sensory environment itself. So if you think of the environment itself as having varied levels of complexity, there can be external complexity like lighting, noise, background information, even the temperature of the room could impact visual functioning or availability for using your vision. Interaction or social exchange, if someone's talking to your child or touching or interacting with them, they may not be able to use their vision as efficiently because there's an increase in the multisensory complexity that's happening. There's just too much going on, so I'm turning my vision off. And positioning and trunk support is huge. It's a really important one. So that's one where vision really, really needs to work together with PT and OT to sort of maximize what are the best positions for different activities. So there's those external factors, and then there's also internal factors that, as you know, impact availability. They also impact vision. So whether your child's feeling tired or hungry. 5 minutes? Cool. Oh yeah, okay, got it. Okay, so there's internal factors as well, sort of the biophysical factors. They really do have an impact on visual functioning. So it's important for everybody to have a good sense of that. The reason for this photo is to really drive home that in PT activities, in PT and OT especially, don't expect as strong or as functional a use of vision as when the child is stable. If the child is focusing on physical trunk balance and support, that's what they're focusing on. And it's too hard to use their vision in those activities. That's okay. Those are still critical goals to focus on, but don't expect vision to be addressed in those activities unless your child is way past that. Okay, so think about the busy classroom, especially the busy preschool classroom. Look at how much complexity is happening in this environment. Massive, dramatic amount of complexity. There's so much visual information. There's bright light happening. You can imagine there's kids screaming and teachers screaming. So making space in a room like that, depending on how much space you have, making space that is not as visually busy, is not as difficult to deal with. And people will always say, especially school administration gets defensive at this one and says, well, you know, you've seen the size of our classrooms and we have, 7 other kids to deal with. This is a classroom in a preschool in Queens that is about the size of a closet and has, 6 kids in it, all in Riften chairs and lots of busy stuff happening. And this team made, with a little sound wall and a board, they made a little space for a little preschool student with CVI so that during downtime activities, during sort of activities when they were really trying to focus specifically on vision, she would go into that space with a teacher. So this is behind that little sound wall. And she'd be able to use that space to look at things, right? So it's always possible to make that adaptation. It's important to note that it is not the child's vision that's fluctuating. This is a common misunderstanding with CVI, that kids with CVI have constantly shifting, fluctuating vision. It's not their vision that's fluctuating, it's the complexity of the environment that's fluctuating. And you may not be able to see that complexity because it might be internal, right? It might just be how the child's feeling that may actually have an impact on their use of vision. But very often it is something that is within our control, like lighting and positioning. I'm just going to do one more characteristic and then turn it over to questions for a couple minutes, because this is another one that's really critical. And this is the characteristic of light. We used to talk about this as light gazing or non-purposeful gaze. Kids with CVI staring compulsively at bright primary sources of light. Right? That's light gazing. Or non-purposeful gaze, that sort of just staring off or staring past something or almost like through it. Non-purposeful gaze is purposeful. It actually serves the purpose of, I'm trying to pay attention to you right now, but I can't look and pay attention at the same time, so I need to look away. So the thing that you never want to say to a child with CVI is, look at this, look at this, look at this, look at me. Because the child's trying to attend if they're looking away. They need that time. Right? So instead of saying, look at me, look at this, adapt or change the environment. Light gazing, very typical. Also note the activity that's happening here. It's a sensory complex, busy activity that requires a lot of focus. So it's important for the child to be able to look away at that activity. Or if you're ready to take it to that next step of adaptation, put something red on the spoon. Consider also the view from a tilted chair. What are kids with CVI used to looking at, especially if they're in tilted or Riften chairs? These horrible panels of light. Right? So if you're focusing information right here, right in front of them, and the child's faced up that way, what field of vision are you using? Their lower field, which is the one that's the most difficult. So you're going to have to either tilt their chair down or else move the information up, right? Or face them away from light. With that, I'm just going to turn it over to questions. If you're with me this afternoon, I'm going to get specifically into intervention and phases. Anybody have any questions?
Do you ever run into specific objects or certain things that just maybe kids with CVI, it just drives them nuts. I don't know if other parents have this, but there's just certain things like bouncy houses, car washes, maybe it's a complexity thing, but there's just certain things that he'll handle great and certain ones that drive him nuts. An obsessive, I love it and I want it, but then I hate it, that kind of stuff. Do you ever see that in kids with CVI?
Thank you. That's a really great question. Yeah, that is extremely common to kids with CVI. And you have to kind of pull apart what is it that is working or not working for any particular visual target or object or environment. So I had a parent tell me the other day, I don't know what's happening. My daughter just totally fine and happy to go in most environments, and at the grocery store freaks out every time. What's happening at the grocery store? Absolute chaos and bright light, right? Visual clutter everywhere. Moving around, other people moving past. It's very overwhelming and confusing. And so providing some extra stability in that environment might be the trick. The other thing that it could be, if it's not complexity, if it's not visual complexity of the array and of the sensory environment, it could also be novelty. So things that are familiar to kids with CVI, they have an easier time looking at. Things that are new, they have a harder time looking at. So kids with CVI may tend to have these really strong preferences for items, but it's not a sort of like autistic restrictive interest. It's often misdiagnosed as that. It's really that it's something that's been seen more often, and so it's easier to see. Yeah, thanks. Great question.
Hi, Tim Benke at the Center of Excellence here at Children's Colorado. So that was a great talk.
Thank you.
And so what I do when I handed back my consult note to the patients that I see is I put a statement in there that based on your talk I need to update, but basically says your child I think has cortical visual impairment and therefore has limited educational experiences that need to be addressed according to the IDEA. So I'm going to tweak that a little bit more to also include, I say that they need to see an ophthalmologist, but they also need to see one that recognizes CVI. It's more, very often I've seen children and I said, do you think your child sees okay? Well, the ophthalmologist said that my child sees okay. And then I'll say it again. And because there's often some cultural differences that patients don't want to disagree with their doctors, it's on the fifth time I ask the question, do you think your child sees okay? No, they don't see okay. And so finally we get around to this issue that you're talking about. The other thing that I would say is in terms of diagnosing with CVI, you know, the three criteria, the neurologic event, that I don't think that we can say that it's the seizures in CDKL5. I think it's an inherent part of CDKL5 that whether or not it's uniquely tied to the seizures, we can't say yet. I think it's just something that's part of CDKL5. Again, that's my opinion, but there it is. Anyway, very great talk. I enjoyed that.
Thank you so much. Yeah, no, I really appreciate that too. I'd like to speak about that specific impact with you maybe later about what is it that's causing CVI in kids with CDKL5. I kind of assumed it was seizures, but it's any kind of impact on the brain.
I was wondering about age. My daughter's 15. Mm-hmm. She's in an adapted, in a severely impaired school and the setting, and they do adapt for vision a lot. And just trying to think about, is there a window where we slow down on intervention? And I know that's a hard question to answer. I think the brain is plastic, and I do think she continues to learn. But it takes a lot of time to assess and adapt, and so I'm just trying to weigh that against other things. And also, we have an eye gaze system, and how do you find children with CDKL5 with eye gaze and how they interact with that?
Those are both really great questions, too. So the first question, it's actually an easy question to answer. There's absolutely no age threshold for intervention that works for kids with CVI. At any age, you should expect to see improvements. I've worked with a 21-year-old with a newly acquired traumatic brain injury who made significant improvements with intervention. Worked with teenagers. What you will see, of course, because of neuroplasticity, is you'll see it may take a little bit longer to make certain kinds of progress. And so in general, it's sort of recommended that functional vision assessment should be once every 3 to 6 months for kids up to age 5, and once every 9 to 12 months for kids above age 5. sort of a rough estimate, but you should definitely see progress. Second question about eye gaze system, I'm going to address very specifically in my session this afternoon, but for anyone who's not going to be here this afternoon, the one thing I would say is that it's about, can your child use eye-to-object contact, which really doesn't occur until around 5 or 6 on the CVI range. 4 or 5, 4 to 6 on the CVI range. If your child's assessed with the CVI range and is not at 4 or 5 on that continuum of 0 to 10, eye gaze system is in no way appropriate. Right? If they're past that, then all the other criteria for eye gaze system. Yeah, thank you.
Thank you for your talk. This is really great. I had a question about the light intensities and how they make an impact. Like, can there be something which is true bright, or can there be something which is not at all bright and the child may have difficulty seeing? So how do light intensities gauge with respect to CVI?
Yeah, that's a great question. I think that in general, sort of bright, natural light is what's going to be most attractive to kids with CVI. As a sort of usually we talk about that as like a distractor. Like it's distracting the child from using her vision functionally because there's this bright light that I'm interested in looking at. So the brighter that light is, the more distracting it's going to be. But it's actually probably dimmer and more indirect light, but backlighting. That's going to be really important for kids with CVI in a functional context. So I've actually seen a child with CVI who was reading large print on an iPad, maybe 28-point, 32-point font on an iPad, doing really wonderfully. If you actually put that same print, same size on a piece of paper, couldn't read it at all. And it's because the backlighting from the iPad. And so that, I think, says something about the density of lighting and the kind of lighting that might be helpful for supporting or anchoring visual attention, as opposed to like just what's distracting. It's a good question. Probably really individualized, though. Yeah, that's distracting, definitely. Especially if you're in a stroller or a Riften chair and you're facing up at this bright light. But windows and sun as well. Yeah, sorry.
No, you're good. So we're at 11:15 right now. Just want to quickly thank you, Chris. This was outstanding.
Thank you.
Thank you.
Thanks so much.
So in this room, we are scheduled to talk, connecting through communication, forming initial connections anytime, anywhere. And Judy, who gave our keynote speech, is going to be talking in this room. And then in Aurora 3, CDKL5 evaluation and treatment of the child using a multi-system approach. And we'll be looking to hear from Margaret Spring, who's also an occupational therapist. So we'll give everybody a few minutes to get settled. Thank you.
Can I just say really quickly, if anybody wants to come and talk to me and take my card, wherever you live in the world, I can try to help you get resources and information specific to your kid.
Thank you, Chris. It's excellent. Thank you.